Heart attack and cardiac arrest. I've come across a number of individuals, both healthcare professionals and members of the lay public, who use the two terms interchangeably. Okay, given that maybe perhaps the healthcare professionals are junior or otherwise, but the important thing is that the two terms are not one and the same. In fact, they are categorically different. I'm going to explain how so. Let's start with the more commonly known heart attack, the technical term for which is myocardial infarction. Myo, muscle, cardiac, which is one of three types of muscle solely confined to the heart. Infarction meaning death. Infarction is completely different from ischemia in that infarction is irreversible. Ischemia irreversible, as seen in angina. There's a separate video done on that. Myocardial infarction is a defect in what I would refer to as the plumbing system of the heart. Let's appreciate the heart is a muscle that in the average adult, healthy adult human being beats 72 beats per minute. When muscles contract, they undergo respiration. Respiration, there are two types, aerobic and anaerobic. We'll keep to aerobic. Respiration, the process by which we create energy in the form of ATP. That energy is required to enable the contraction in the first place. Respiration has a demand for oxygen nutrition. Those nutrients and oxygen are met, that demand is met, and those products are carried by oxygenated blood. The heart has its own supply and its own vascular system. The coronary arteries of the heart are the vessels that supply the heart itself with this respiratory demand. If that respiratory demand is not met, the muscle tires. It's what we experience as a stitch when we're running, for example. But that again, like I say, is reversible. Here, infarction would be, so if that demand is not met, that means there's an occlusion somewhere. And that's where the plumbing defect comes in. So if I use my model, you'll appreciate anatomical structure of the heart and anatomical representation. Let's just use, in fact, there is a good demonstration here. They've actually demonstrated a darker area here. What we've got is the coronary arteries, the red ones. We've got the veins as well, so the red arteries. Let's say there's a blockage over here, for example. That will prevent, and I'm not going to use that, but there's a blockage here. That means no further blood is supplied past this point. That blockage could be due to a blood clot, an atheroma due to the process of atherosclerosis. Notice the clot here will mean that blood cannot pass this area, so all of this area here is being supplied by these branches that come off that artery. That will undergo infarction. If that blockage was higher up, let's say for example here, then there's a greater region of muscle that's going to be defective. The interesting thing here to point out is that we have got some more blood vessels. Okay. The point here being that the occlusion is here, therefore it's a regional area. What we look for after an MRI, one of the investigations, an echocardiograph, which is essentially an ultrasound of the heart, we are looking for regional wall motion abnormality. The rest of the heart will continue to pump because there's no defect there. The defect here, as just shown, is purely in the blood vessel itself. A localized blood vessel and therefore a region, be it small or large. Myocardial infarction, defect in the plumbing system. On the other hand, we've got cardiac arrest. Cardiac arrest is defect in the electrical system of the heart. Okay, so again, appreciate the anatomy of the heart. We have the four chambers, the two top ones, the two atria, and the two bottom ones, the ventricles. The right hand side and the left hand side are separated by a septum, a bit like the nasal septum that separates your left and right nostril. You've got the cardiac septum separating the right from the left. That's important so that the two types of blood, the oxygenated and the deoxygenated blood, do not mix. The cardiac septum, however, is a little more sophisticated than is the nasal, in that it contains the electrical system of the heart, the bundle of His. The bundle of His, you have a number of branches, the right bundle branch and the left bundle branch. The left, which is subdivided into the left anterior fascicular and the left posterior fascicular. Keeping it simple, we've got this whole wiring system in the heart. If you caused a blackout, so a power cut rather, then the heart in its entirety, the whole thing, will stop beating. And just to bring that together, here we are. We've got our chambers, the atria, and then the ventricles at the bottom. There's your valves, and then that's the cardiac septum, the region that separates the left and right sides. Okay, that septum there. It's inside here. You find the electrical conductance of the heart. In a cardiac arrest situation, the whole heart stops beating. Now, that is not to say that the heart is reliant on nervous impulses, because it is not. Cardiomyocytes, or heart cells, heart muscle cells, have one of the many phenomenal properties known as automaticity, which means that they are self-initiating, they are self-propagating. They do not rely on electrical impulses, or nervous impulses rather. There's electrical activity but nervous. You can remove the heart from an individual, place it on a table, and it will continue to beat. Equally important to say and note is that this is not to say that the heart is cannot be influenced by either nerves or the neuroendocrine system, because it can and it is. Adrenaline is one of the most common. Caffeine increases heart rate. Adrenaline increases heart rate. The vagus nerve, cranial nerve number 10, has both sympathetic and parasympathetic fibers and properties, and therefore influences the heart rate to either increase or decrease. So the heart the muscles are myogenic, it has automaticity, it can continue to beat at its own accord without the need for external input, but it can be influenced. The final point I want to make is when we are learning first aid, we are taught cardinal signs of myocardial infarction, and then we are taught CPR. As an individual, that doesn't sit quite right with me, in that the teachers, the instructors of first aid, do not clarify a key difference here between MI and cardiac arrest. Why am I stressing this? Because in an MI situation, a myocardial infarction situation, you do not perform CPR. You only perform CPR when the patient's airway, breathing, and compromised. So ABC becomes circulation becomes compromised. Why? What are you doing in CPR? The chest compressions occur when the patient has gone when the patient has entered a situation cardiac arrest. Why do we then teach the two together? Because MI can easily progress into cardiac arrest. The heart can actually just stop beating altogether. So with the cardiopulmonary resuscitation, you are manually beating the heart, which it would be doing otherwise at 72 beats per minute. So that's why in first aid we teach the two together. But I think important to clarify is, why do we teach the two together? Because of the high level of risk of the MI progressing into cardiac arrest, and the latter is what warrants the CPR, the chest compressions, not the former, not the MI.